Yeah, we are live now. With all your permission, I'm beginning this session. Good afternoon, everyone present here. I am Faraz from Clarnet. Clarnet is very proud to be a part of this session as a digital partner. Clarnet is India's digital live CME platform where doctors generate medical content. With all of you, I'm presenting a short video on Clarnet. Uh, th- Thank you so much all doctors for watching the video, and you all are requested to visit our website, that is www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that you can also read. By taking not much time, I would like to invite and hand over this session to Dr. Prashant Karia, sir, Honorable Secretary of NNF Gujarat. Over to you, sir. Kindly proceed from here.
Thank you so much, Faraz. On behalf of NNF Gujarat, I, Dr. Prashant Karia, welcome one and all to today's Neonatal Pathshala, a PG seminar. I request our President, Dr. Deepen Patel, to welcome one and all.
Thank you, Dr. Prashant, for introducing. On this neonatal academic digital talk, today on behalf of Gujarat NNF, I welcome you all for this innovative digital platform in which we conduct regular neonatal academics on every Wednesday. I welcome Dr. Tushar Parikh sir and Dr. Kunal Ahia for accepting the invitation in this PG seminar. I also thank Dr. K. Samir, who is now presenter for this seminar. Over to you, Dr. Prasad, for a detailed introduction of our experts.
Thank you so much, Deepen bhai. Today we are having K. Samir from Karamsad Medical College, who is going to present a PG seminar. And with this, we are having a two expert. First is Dr. Tushar Parikh. He is DM Neonatologist from Pune, an excellent teacher, having very good academic skills, presented many publications, more than 40 publications, and invited to many conferences as a speaker. So we welcome Dr. Tushar Parikh, sir. Along with him, we do have Dr. Kunal Ahia. Kunal Ahia is a neonatologist from Rajkot, and he was editor of NeoBliss for 2 consecutive years and done a wonderful publication of NeoBliss. So we welcome Dr. Kunal also. I request K. Samir to start the presentation. His PG seminar presentation will be of around 25 to 30 minutes. And after that, there will be some question answers from the audience, as well as the experts will be discussing few more things. Thank you so much.
Thank you, sir. Good afternoon, everyone. Today's topic of the seminar is neonatal lung ultrasound. In recent years, lung auscultation is being replaced by lung visualization. So lung ultrasound is considered as the stethoscope of the new millennium. Indications for the initial point of care lung ultrasounds is a neonate admitted with respiratory distress, prenatal suspicion of lung lesions, a neonate with sudden deterioration of respiratory distress, USG guided thoracocentesis. Indications for follow-up of point of care lung ultrasound examinations are to guide respiratory support, to determine the need for repeat surfactant therapy, to guide changes in the level of respiratory support after surfactant delivery, and for follow-up of improvement after thoracocentesis. Lung ultrasound is a dynamic technique which allows for the analysis of lung movement in real time. Besides, bedside diagnosis can be done. It is quick avoidance of irradiation. It is cost effective, and multiple examinations can be done. Neonates have thinner thoracic wall, smaller width of the thorax, which makes the visualization of almost entire surface of the lung possible. Lung ultrasound requires a B-mode ultrasonograph, which I would be describing later what it is, and a high-frequency linear transducer. Lung ultrasound is mainly based on artifacts. The main artifact arises from the air and fluid mixing within the thorax. Most signs are dynamic. All signs of lung ultrasound arises from the pleural line, which is below the hyperechoic line that presents the rib. And almost all chest disorders occur in contact with the surface. This explains the potential of lung ultrasound. These are the principles of lung ultrasound on which it is based. The European Society of Pediatric and Neonatal Intensive Care recently published the guidelines of point of care lung ultrasound focus, which mentions the usefulness of lung ultrasound for the diagnosis of the main respiratory diseases in neonates and pediatric patients. Here you can see the number of papers and articles written on lung ultrasound has been increased over the period of time. Applications of lung ultrasound of US in an ICU, such as airways and beyond, movement of diaphragm and its function, thymus and upper airway evaluation, for diagnostic purpose of respiratory distress syndrome, transient tachypnea of newborn, pneumonia, pneumothorax, and atelectasis, for the guidance case of lung recruitment, pleural effusion drainage, pneumothorax aspiration, and early prediction for the need of surfactant, bronchopulmonary dysplasia prediction, and extubation failure. So these are the probes which are helpful in lung ultrasound. Linear probe with a frequency of 8 to 50 Hz. It helps for identify the superficial structures. However, the deep structures are poorly visualized. Curvilinear probe, which is B of megahertz 2 to 12, it is best all-round probe for lung ultrasound. It helps for the diagnosis of effusion and consolidation. And sector phase probe, which is C, 2 to 6 megahertz with high penetration, small footprint, and image quality is not so good in this probe. Linear probe is also known as vascular probe. Curvilinear probe is also known as abdominal probe, and the sector phase probe is most commonly known as cardiovascular probe. Coming to technical aspects of lung ultrasound. A high frequency linear probe of 6 to 13 megahertz is the probe of choice for the ultrasound exploration of the chest. Due to the size of the newborn's rib cage, it allows obtaining a high resolution image. Lung preset is set on the ultrasound machine. The transducer is oriented in a longitudinal plane, and bilateral lungs are examined in supine and lateral positions. Each side is divided into 3 areas. Anterior area, which lies between the sternum and the anterior axillary line, lateral area between the anterior and the posterior axillary line, and posterior area between the posterior axillary line and the spine. Bratt et al. Had described 3 examination areas for each lung: upper anterior, lower anterior, and lateral, to predict the need for surfactant administration, and it is recommended to use warm ultrasound gel to avoid discomfort in the newborns. So this is an image which shows the area between the sternum and the anterior axillary line is the anterior aspect. The lateral aspect lies between the anterior axillary line and the posterior axillary line, and the posterior aspect lies between the posterior axillary line and the spine. And the anterior line and the anterior segment is further divided into upper anterior and lower anterior segment. So the anterior areas are useful for the diagnosis of pneumothorax, and lateral and posterior segments are useful for the diagnosis of consolidation and effusion. Coming to the modes of lung ultrasound. Mainly there are 3 types of modes. The B mode, which is a 2-dimensional mode, which is the most common. It allows identifying the dynamic signs and diagnosing the most important pulmonary diseases in newborn. M mode, it allows studying a point over a time. And color Doppler, it identifies the blood flow in consolidations. Anatomy of the rib cage. Rib cage consists of the skin, subcutaneous tissue, and the muscles that overlie the ribs. Below the ribs are the parietal and the visceral pleura that slide against each other with each respiration. In a healthy lung, air completely scatters the ultrasound waves. What is pleural line? A curvilinear line, brightly echogenic and smooth line that originates from the reflection of the pleural surface with thickness of less than 0.5 millimeter. It is the most bright structure which we can see in the lung ultrasound. Together with 2 adjacent rib shadows, this line forms the bat sign. Here you can see the pleural line along with the rib forming the bat sign. Lung sliding. In a healthy patient, the pleura can be observed moving to and fro. which is synchronized with the respiration. Movement of the parietal against the visceral pleura during respiration is called as lung sliding, whose video I will be showing later. In the M mode, the image appears as seashore sign, that is linear pattern in the tissue superficial to the pleura represents the sea, and the grainy and the sandy appearance deeper to the pleura represents the shore. This is the video which shows the sliding of the pleura, and this is called as lung sliding. Lung ultrasound is the study of artifacts. When the ultrasound transducer is placed on the chest wall, images are obtained as a result of interaction of the ultrasound beam with the pleura and the lung parenchyma, which generates horizontal as well as vertical artifacts of varying ecodensity. When the lung is predominantly aerated, these artifacts will vary depending on the relative amount of air and fluid in the lung. This means that the structure below the pleura is air-filled lung cannot be visualized, only artifacts will be seen. However, if the lung is highly fluid-filled, then it can be directly visualized as ultrasound waves will cross the lung. A-lines. A-lines are horizontal, hyperechogenic, equidistant lines from one another below the pleural line, the spacing of which is equal to the distance between the skin and the pleural line. It is a reverberation artifact due to ultrasound waves being repeatedly reflected between two surfaces, that is the pleura and the transducer. In this way, the pleura acts as a mirror of the lung. A-line pattern together with lung sliding assures that there is absence of any lung pathology. So this is the image of A-lines, horizontal equidistant lines. B-lines. As the air content in the lung parenchyma decreases and the amount of fluid or the cell deposit in the interlobular septa and the interstitium increases, vertical reverberation artifacts called B-lines appear. These lines indicate an ultrasound sign of loss of lung aeration. They are characterized by being vertical, hyperechoic, and well-defined. They arise from the pleural line and are directed to the lower limit of the image, blurs the A-line, and shows a synchronous movement with the pleural sliding. B-line is considered to be pathological when two or more B-lines are observed in a longitudinal scale. B-lines can be present in different diseases such as congenital heart disease, heart failure, pneumonia, atelectasis, pulmonary edema, and transient tachypnea of newborn. However, isolated or non-confluent B-lines may be present in healthy newborns in the first start of life during the transitional period. These are the B-lines which is being shown in this image, vertical lines termed as B-lines. Coming to ultrasound patterns in the different respiratory diseases of the newborn. First thing which we'll be dealing with is pneumothorax. Pneumothorax is defined as the presence of air between the visceral and the parietal pleura. This abolishes the lung sliding on the B mode imaging. A lung ultrasound has a higher sensitivity and specificity in early diagnosis of pneumothorax in neonates compared to chest X-ray. Lung ultrasound allows faster diagnosis in chest X-ray, that is 5.3 minutes versus 11.7 minutes respectively. Pneumothorax, A-lines are present. The M mode reveals absence of seashore sign and the appearance of a new sign called as the barcode sign or the stratosphere sign, which is observed as parallel lines due to the presence of air between both the pleura. So here one side you can see the normal lung, which shows positive lung slide and the seashore sign, and the other images of a pneumothorax in which there is no sliding, leading to the formation of the barcode or the stratosphere sign. So how do we approach case of pneumothorax? First, in ultrasound, we have to see whether there is lung sliding or not. It is a sensitive method, but it is not specific. Secondly, appearance of only A-lines can be visible and their absence of B-line. Presence of even one B-line is sufficient enough to rule out pneumothorax. The third point is presence of lung point. Lung point represents the transition zone, that is both sliding, non-sliding pleura with A-lines and sliding pleura with B-lines are present. This is the most specific sign for the diagnosis of pneumothorax. So here in this image, you can see that below the parietal pleura, the granular pattern is replaced by the horizontal lines. This is because of the abolition of the lung slide. So lung point is a transition zone between the absence of lung sliding and the presence of lung slide. Coming to algorithm of lung slide, pneumothorax, first you have to see whether the lung is sliding or not. If it is sliding, then definitely it is not a case of pneumothorax. If the lung is not sliding and there is absence of B lines, then definitely there can be a case of pneumothorax. You have to see for lung point. If lung point is present, then pneumothorax is present. If lung point is absent, then check for lung pulse. Lung pulse is a transmission of cardiac activity through motionless lung or near motionless lung. So presence of lung pulse indicates absence of pneumothorax, and if lung pulse is absent, then pneumothorax is definite. So this is a video which shows the lung point where one side the lung is sliding, whereas the other side there is no sliding between the pleura of the lung. Coming to interstitial syndromes, B lines may be present in neonatal lung diseases such as respiratory distress syndrome, meconium aspiration syndrome, transient tachypnea of newborn, and bronchopulmonary dysplasia. Depending on the pathology, they may be present in one or both the lungs. Transient tachypnea of newborn. It is characterized by delay in clearance of the lung fluid. Kopeti and Katarasi described as a lung ultrasound sign called as the double lung point, which is pathognomic of transient tachypnea of newborn, which is 100% sensitive and specific. Double lung point is characterized by pattern of A lines in the upper chest and coalescent B lines in the basal areas. However, subsequent studies have showed that this sign is present only in 38.4% of the cases in the first 24 hours of life. So this is the image which shows the upper lung field and the lower lung field, and between this is the double lung point. In the double lung point, this indicates that in the upper lung field there are A lines present, and in the lower lung fields there are compact B lines. Respiratory distress syndrome. Uniform bilateral involvement can be seen. Abnormal pleural line, thick irregular with subpleural consolidations indicating alveolar collapse. Bilateral whiteout lungs can be seen with extensive compact B lines. Absence of A lines, decrease or disappearance of the lung sliding, lung consolidation with air bronchogram, presence of lung pulse, and even pleural effusion can be seen in these cases. So this is the image of respiratory distress syndrome showing thickened pleural lines and diffuse vertical B lines. Image showing subpleural consolidation, air bronchogram, and X-ray showing ground glass opacification, which is the characteristic of respiratory distress syndrome. Coming to meconium aspiration syndrome, this is a lung disease caused by aspiration of meconium. The ultrasound pattern is characterized by subpleural consolidations, coalescent B lines in absence of A lines, consolidations with air bronchogram. Large enough atelectasis can be present in such cases, which can cause absence of lung sliding. Because of the meconium redistribution and dynamic character of the disease, these patterns can change over the period of time. So this is the image of meconium aspiration syndrome showing thickened pleura with unevenly distributed subpleural and parapleural, subpleural and parenchymal air bronchograms. Pleural effusion. Fluid can be seen as an anechoic image between the visceral and the parietal pleura. A lung ultrasound not only allows to diagnose pleural effusion by detecting even small amount of fluid, 5 to 20 ml, with high sensitivity and specificity, it also monitors its course by estimating the pleural effusion volume and determining the area where to perform the lung-guided thoracocentesis in order to reduce the associated complications. So this is the image of pleural effusion. The signs, what we see in pleural effusions, there are various signs. First sign which we can see is the sinusoid sign. Using the M mode, the back and forth movement of the parietal and the visceral pleura is observed during respiratory cycle. as you can see, the sinusoid sign and the M mode. And the jellyfish sign, which is seen on the B mode. Lung is partially collapsed with the lung tip flapping freely in the effusion. Partially collapsed lung with lung tip freely flowing in the effusion. The squat sign, it is a static sign that appears when the linear probe is placed longitudinally on the chest. Parietal pleura forms the upper layer. The acoustic shadow of both the ribs forms the boundaries which are not visible here. And the lower boundary is formed by the Whistler pleura. So this area is called as the squat sign. Curtain sign. Curtain sign is the movement of aerated lung over the pleural effusion during inspiration, leading to the curtain sign. Into pneumonia. In pneumonia, alveoli are filled with inflammatory exudates, which leads to the collapse of the alveoli. Because of lack of air in the alveoli, propagation of the lung ultrasound is facilitated. Pleural line is irregular, coarse, and hypoechoic in 90% of the cases. Sonographic consolidation profile or lung hepatization as it resembles the liver tissue. B lines arising from the subpleural consolidations. It is static, dynamic, and fluid air bronchograms can be seen. Lung sliding is absent in 75% of the cases. Approximately 1/3 of the patients will have pleural effusion and anechoic area below the pleural surface. In pneumonia, below the pleura, infected lung looks hypoechoic with irregular ball. A lines disappear, and there is something called a strut sign. If consolidations are so extensive that it looks as if chunks has been taken out of the lung and echoes areas are very poor. So this you can see the consolidations below the pleura. Image showing consolidation with effusion and hepatization of the lung. It looks almost similar to the liver. And presence of air bronchograms. Lung ultrasound scoring system. So 0 seen in A pattern, which is defined by presence of only A lines. 1 is B pattern, which is defined as the presence of more than 3 well-spaced lines. 2 is severe B pattern, which is defined as the presence of crowded and coalescent B lines with or without subpleural consolidations. And 3 is extended consolidations. So 0 means normal aerated lung, 1 means moderate loss of the aeration, 2 is severe loss of the aeration, and 3 is complete loss of the aeration of the lung. Airway ET tube position can also be seen by lung ultrasound. Main stem bronchus intubation is as high as 8% of all intubations. Point of care ultrasound helps to prevent this being a rapid and a real time, preventing the barotrauma, atelectasis of the contralateral lung, and worsening of the respiratory failure. So this is the ET2 which we can see in the lung ultrasound. The lack of sternal calcification allows the ET2 to be directly visualized in the relation to the intrathoracic structures. The probe is placed in the suprasternal view, in sagittal view, till the visualization of the double line of the ET tube is seen. Optimal tube position was determined to be 1 centimeter above the aortic arch on ultrasound, which correlates with 0.5 centimeter above the carina on chest X-ray. There is small window which needs manipulation, which can cause discomfort and agitation in the newborn. So this is the image which shows the tip of the ET. This is trachea. This is the arch of aorta. And this is the level of carina. Diagnostic accuracy of lung ultrasound. For interstitial diseases, sensitivity and specificity of lung ultrasound is 93%. For alveolar consolidation, sensitivity is 90% and specificity is 98%. For pleural effusion, the sensitivity is 94%, specificity is 97%. And for pneumothorax, sensitivity is 100% and specificity is 96%. There is higher diagnostic accuracy of lung ultrasound than physical and chest X-ray combined. Limitations of lung ultrasound. Lung ultrasound cannot directly visualize any lesion located deeply in the lung. B lines, if present, cannot differentiate lung versus cardiac causes. It is operator dependent, and use is not possible in patients with subcutaneous emphysema or over distension due to excessive mechanical ventilation. Coming to conclusion, lung ultrasound has gained consciousness as a safe, non-invasive, and radiation-free tool that allow neonatologists not only to perform a rapid bedside examination of the respiratory status, but also to interpret findings and represent and repeat the examination by monitoring the response to different therapeutic strategies. The implementation of lung ultrasound in daily practice allows the diagnosis of the most important respiratory disorders with high accuracy, thus enabling the reduced exposure to the ionizing radiations from chest X-rays in neonates. Ultrasound findings should always be integrated with the patient's clinical signs and symptoms, as well as with other diagnostic methods. These are my references. Thank you.
Yeah. So good presentation, Dr. Samir.
Thank you, sir.
Audience, I would request all the audience to put questions if there are any in the chat box so that we can take them up for discussion. Dr. Samir has rightly said, basically lung ultrasonography is assessment of the artifacts and not of much of anatomy. So in a way, if you look at ultrasonography of any other organ, you have to know the anatomy, spatial relations, vascularity, etc. In detail so that you can interpret them. But for lung ultrasonography, you really don't need to know the anatomy so well, but you need to be able to assess the artifacts that are created. So when you're using a machine, make sure that don't use algorithms that will reduce the artifacts, because in that you will not be able to assess lung properly. Second important thing, as you said, is lung ultrasonography will help you assess superficial structures more and not the structures which are deep towards the hilum in the lung. So again, that is another limitation that we have to remember, that we are able to assess the lung parenchyma, which is superior or superficial to the skin surface. Number 3, as you said, there are different variety of probes that we can use for assessment of the lung ultrasonography. And that also tells us that you can use the dedicated pediatric probe of 7 to 8 megahertz, which is a small footprint probe with a sectoral image. And that particular probe also you can use for assessment of the lung ultrasonography. However, some of the signs which are described, such as double lung point or so other signs, double lung point especially, we have to remember that they are assessed on the linear probe basically. And so when you interpret those images, you have to also remember that which type of probe is used and for the assessment. Also, when you assess the lung, if you look at adult ultrasonography, I think you rightly suggested lung areas. In adult ultrasonography and most of the neonatals also, when they do ultrasonography, they will assess flap point, that is posterolateral alveolar point, which is the point in the axilla and mid-axillary line, and the lowermost point where the diaphragm attaches so this is the thoracic wall and the diaphragm where it attaches here, and you assess it from here. So that is called as flap point. So that is something which is assessed in most of the neonatologists will assess that, and adult ultrasonography is also demonstrated at the flap point you have to assess. A lot of findings of the lung ultrasonography, such as pleural effusion or say jellyfish sign which you described, all those they are assessed at that flap point. So a special mention is done generally of the flap point when you are assessing. So anteriorly 2 areas, laterally 2 areas, and flap point. Generally, you don't turn the baby around and check the ultrasonography on the back areas. Again, there are various protocols which are described that we have to again appreciate. But most of the neonatologists, what will do? They'll do the ultrasonography in the 2 anterior segment, lateral segments, and the flap point. So that way, there are 10 points that you do the lung ultrasonography. But again, as I said, when I say this, there are a lot of variations also in protocols. As Dr. Samir has rightly pointed out, that this is an evolving specialty, and there are a lot of publications which are coming. Our knowledge in adult ultrasonography started from 80s, when Daniel Lichtenstein and group from Paris, they questioned why you're not using in lung ultrasonography for lungs. And from that point in time, our understanding is increased, and it's just recently that last 7-8 years that it is being used in the newborns, say maximum 10 years, and therefore new science are which are coming, and that we can we have to take it with pinch of salt, many of this science, because then our knowledge is increasing, and then we kind of come to know which exactly is more valuable or not. Also, briefly one can understand A lines indicate air, B line indicates fluid in the tissue or water in the lungs, and people have described C line also for indicating consolidation. So in pneumonia patients consolidation, you will be able to see C line, which is not demonstrated, that you can see that you will be able to see C line, but not very common. Shred sign is like a more of a diagnostic for your lung consolidation. Now, Dr. Samir also said about lung aeration score, and if the aeration score is 0, it indicates that a good aeration or ventilation of the lung, and mild, moderate, severe kind of hypoventilation. There is something called as lung fluid score also, or B line score also it is known as, and that is completely calculated based upon the B lines that you see in the lung. And again, in all these lung areas, you demonstrate the number of B lines that you see in each intercostal space, and then you add up, and then you see the amount of water in the lung, and that has got good correlation with pulmonary edema in adult patients. And in the newborn also, we have used our unit, we have done a scoring system, and we have our DNB student, DNB neonatology student Anupal Gowda has done this study, and that we published in last year in Lung India journal, where we have shown that there is a good correlation with RDS. So babies with severe RDS has got higher lung score, and that correlates well with the need for surfactant. So lung ultrasonography can help you identify severity of the lung disease, presence of RDS, as well as the severity of RDS and need for surfactant that you can predict with help of lung ultrasonography. About diagnostic accuracy, again, we have to, one thing point here I want to emphasize is that, say for example, when you're using a modality, we have to remember the strengths of that modality and where to use that. Say, for example, if you want to use ultrasonography for brain, if you talk about cerebral or perinatal asphyxia, ultrasonography is not such a good modality. But say if you want to talk about IVH, then ultrasonography is the best modality. Similarly, for the lung ultrasonography, you have to remember that lung ultrasonography is a good modality to identify pleural effusions, identify if there is any empyema, because X-ray will not give any clue whether it is empyema, or it will just give you radio opaque lesion density. Thirdly, it will also help you identification of septations and volume of the kind of collection. Plus, sometimes you have lung completely opaque. Now you do ultrasonography and you do X-ray, and you don't know whether it is consolidation, whether it is effusion, or whether it is a pulmonary edema. But these three differential you can easily do with the help of lung ultrasonography. X-ray studies have shown, in adult medicine also studies have shown, that sensitivity and specificity of lung ultrasonography for diagnosis of pneumonia is much more than X-ray. So if you ask me which is the best modality to diagnose pneumonia, it is ultrasonography, not the X-ray, because the X-ray accuracy is to the tune of around 70%, but here it is more than 90%. So I think these are the few silent points which I wanted to highlight. May I ask Dr. Kunal if you want to add anything, and if there are any questions, then we can take those questions.
Yes. Good evening, everyone. Very well presented by Samir, and summarized very well by Tushar sir. Just a few points I would like to add is one thing is that why the lung ultrasound is important, because X-ray, main thing is that X-ray might take some time. So in the setups where there is ultrasound facilities are there, they can immediately be seen, and the time taken for the X-ray machine or the X-ray film to come sometimes takes around half an hour to 45 minutes, which is sometimes the patient might deteriorate, especially in the cases of tension pneumothorax is there. In those cases, the rapidity with which we need to diagnose the condition is very much important. Second thing is, I think most of the all the points have been covered in the topic, and few more points are being highlighted by Tushar sir. Just in ET tube position, I would like to add one more thing is that for the ET tube position, you can give a very slight movement of 1 to 2 mm of the ET tube. Sometimes it is very difficult to find out the tip position or exactly identify the ET tube. Even the double line is there, but still you might not be able to identify it very easily. So at that time, what you can do is you can just move the ET tube slightly, just 1 or 2 mm, so that the movement can be easily been seen on the ultrasound, and you can identify what exactly is the ET tube. There are different measurements are there for the ET tube position also, and there are different, whether you see it with relation with the vessel also, or either you can see it from the top of the arch of aorta to the ET tube tip measurement is there. So it is from the upper surface of the arch of aorta up to the endotracheal tube. Your measurement should be around 0.5 centimeter should be there. So that again, so these two things are very important, and X-ray might take some time, in especially in cases of pneumothorax, as well as for the ET tube identification. Though ET tube identification is not being studied very much, but still it is a very important thing, and needs immediate care, because the baby might not improve even after ventilating the baby. So these are few points which needs to be highlighted, and I think if there are any questions are there, can be taken up.
Are there any questions? I think that chat box is, I think, with.
Yeah, ClearNet. We'll just ask them whether they are having any questions or not. But good presentation. Thank you so much, Tushar bhai and Kunal bhai, for sparing your valuable time. So, Faraz, are there any questions on our platform? I'll just on the Google also, YouTube also.
Yes,
So
I'll
as we
just
Meanwhile, I
check
can
on.
ask the question, Dr. Prasad Bhai,
yeah,
to Tushar sir.
yeah. So as we look for the questions, so I think there are a lot of students who are participating in this seminar, and I think this is an excellent topic for thesis and further research. There are so many things that can be done. It is used for studies are done to show that what is the optimal pressure to recruit the lung. So one can do studies where they can check what is the optimal pressure that you put on high frequency, what is the closing pressure on high frequency. There are studies in animal model that they have done. Also, one can use it for bubble CPAP or CPAP modality, which is the optimal pressure. One can also correlate with PDA and lung water. So there are so many possibilities which are there. When you get hang of this, one can use this for doing further research. A lot of research, I think, needs to be done in this area, because altogether it will help to reduce the radiation exposure in our NICU. Yeah, so Faraz, are there any questions?
Sir, regarding pneumothorax, I want to ask a question.
Sure.
Many times we have seen trans illumination of chest is more easy to do and perform because it is more simple. So, is there any correlation with trans illumination and ultrasonography? Because it is difficult many times, even in experienced hand, to find out pneumothorax if it is small pneumothorax. So, how to go ahead with this?
Yeah, Dr. Samir. Okay, so basically what you said is absolutely right. Basic trans illumination one should attempt, and trans illumination is an easy modality, easy to do, doesn't require much of expertise. But again, of course, we have to remember that if there is a small pneumothorax, anterior pneumothorax, it may be missed. Also, sometimes if the baby is too small, then one may not be able to appreciate the trans illumination aspect. So I don't know any study which has correlated these two things with trans illumination correlation with this. Most of the studies have correlated with X-ray. So this is a good point. I think this again is another point which can add up, two-step study where first time you do trans illumination. If there is nothing there, then one can go for an ultrasound and check if there are any cases. Additionally, you can find out. So I think, yes, again, this is again an area where one has to, and we have to kind of work. And but again, if there are small pneumothorax, especially anterior pneumothorax, that can be easily picked up with ultrasonography. And again, the lung point, that is a point where you place it anteriorly and start going laterally to a point where you see the lung coming into picture. So those seashore sign coming into picture. Before that, you have a sea without shore. And once you reach to that point, as you go laterally, you see a point where the kind of sea starts coming. And you know that that is the point which is the lung point, and which is the kind of an anterior small pneumothorax. But again, I think one can do a study where, you know, they first do trans illumination, and step 2 will be kind of lung ultrasound. Yes, Deepan. Yes, I think.
Thank you. Thank you, sir. Prashant, are there any questions?
Yeah, there were two.
Something in chat box.
Sandeep has asked how it helps if child is on HA for ventilation.
Yeah.
Hello?
So that's what in high frequency ventilation. Now, one of the methods of ventilating on high frequency is that you put a mean airway pressure. We start with 2 or 3 level higher than the mean airway pressure the child is on the conventional ventilation. Now, basically, ideally, what is recommended is that you go on increasing pressure by 1 or 2 centimeter till the time that you have an open lung. So there is something concept called open lung strategy. Now, once the lung is open, it takes little higher pressure to open the lung, but the closing pressure is little lower. So what is recommended is that once you keep on increasing pressure by 1 or 2 centimeter till a point when the lung is open, and once you reach to that level, then you reduce the pressure by 1 or 2, and you keep the baby ventilating at that pressure. Now, this is open lung strategy ventilation. So now lung ultrasonography, because something like aeration score is there, they have tried to use it in the rapid model, and they've shown is that you are able to predict the kind of opening pressure and closing pressure in the lung when the baby is on high frequency. But this is not done in the newborn. So that's the point which I wanted to mention, is that there is so much of scope to study. If I can just share this, I think I had it in 1 second. So this particular slide, I'm sure you can see. So this is Suman et al. Critical pediatric. Now recruitment, can you see this? Opening and closing pressure. So this is a low pressure. As you keep on increasing the pressure stepwise, you'll have the lung which is open, and then you start seeing the pleural, both the pleura kind of opposed to each other. Again, this is not in the humans, this is the reference. So those who are interested can go into this study and do it. And again, this is something which one can think about in the human also. And I mean, see, this is again evolving. This is a fluid. Right now, we don't know, but this theoretically, this can be used for that purpose. This is the reference for those who are interested.
Thank you, sir. One more question from Dr. Piyush is, can USG machine be used for 2D echo and vice versa?
Yes. Yeah, so basically now there are, if you look at the dedicated pediatric probe that we use, that has got a frequency of 7 to 8 megahertz with a small footprint. That is a very small square footprint is there, and that is a sectoral probe. So this particular, if you have one machine with this probe, almost 95% of your requirements will be done. So the same machine can be used for heart, brain, lung, lines, and even for the abdomen. So, I think this answers the question. Same machine can be used for both. Yeah.
Yeah, thank you so much. So these were the two questions which were there on my platform. For us, any questions on ClearNet?
No, sir, I can't see any question till now, sir. On YouTube also, on that ClearNet also, sir.
Fine.
Okay, thank you so much, sir.
So thank you so much. So thank you so much, K. Samir, as well as both of our experts, Dr. Tushar Parikshar and Dr. Kunal. I just request for us to present a certificate. Faraz?
Yes, sir. Just give me a moment. I'm sharing the certificate with you, sir.
Yeah. By the time he is sharing the certificate, just for the knowledge of everyone, that Neonatal Pathshala will be on every Wednesday at 3:30 to 4:30 p.m. By joining on the same ClearNet link, as well as the recording can be seen on YouTube also. Now, as Dr. Dipen Patel, our president, has informed that we will be having a 1 PG case presentation, 1 seminar every month, and 2 sessions by experts every month. So from next month, next week onwards, Dr. Tushar will be having a series of point of care ultrasound in neonates uses a case-based discussion. So that will be moderated by Dr. Mohit Sani, which will be there from the next Wednesday. So every month we will be having a 1 such discussion and 1 expert talk will be there. So that is the outline of our neonatal Pathshala. Faraz, are you ready?
Wonderful, Dr. Prashant. I think good initiative by Gujarat NNF. I think congratulations on this.
Thank you so much, sir. So on behalf of NNF Gujarat, just small token of appreciation, a certificate of appreciation is presented to Dr. Kunal Ayya for being an expert in neonatal Pathshala. And the next for us, for the Dr. Dipen Patel for being a mentor who actually motivated our student K. Samir. So thank you, Dr. Dipen Patel also.
Thank you, Dr. Prasad.
And next, Dr. Tushar Parikh, our eminent expert, for sharing his valuable inputs on the topic and being an expert in neonatal Pathshala. And thank you so much to K. Samir, who actually presented a seminar and done a wonderful job. Thank you, everyone. And we will be meeting next Wednesday at 3:30 p.m. Thank you. Thank you so much.
Thank
Thank
you.
you so much, sir. And with all your permission, shall we close this session, Prashant, sir?
Yes.
Yeah, thank you so much. It was really wonderful to have all of you here and hope to see you again with different topic. We are closing here. Thank you. To have all of you here and hope to see you again with different topic. We are closing here. Thank